Hello, good day. In this discussion in pharmacology, we will be talking about the application of your nursing process in medication administration. Nursing process is a concept that has been introduced to you since level 1, so right now we will apply it in pharmacology or in the way we administer the medications of our patients. Now, our goal here is that at the end of this topic, the students should be able to apply the different steps or phases of the nursing process, identify the common nursing diagnosis related to our medication administration. We hope that you will be able to develop client-centered goals and then formulate nursing care plan for a specific client with a problem related to pharmacology and discuss principles for health teaching related to drug therapy. Okay, so let's start. Okay, in this picture, you'll be able to see a patient, and then the nurse is attaching the ID bracelet of the patient. In medication administration, the value of your identification bracelet could not be overemphasized because your identification bracelet will be a counter check to ensure that you're giving the right drug to the right patient. Without your ID bracelet, you could not ensure if it is the right patient that is receiving the right drug. So be mindful of that in your practice. Now, let's talk about nursing. We know that nursing is both an art and a science. And because of that being an art and science, we utilize a systematic approach to deal with the concerns that we encounter for our clients. May that be in the community setting, in the hospital setting, in the school setting, wherever it may be that we practice as nurses. So this systematic approach that we are using is what you refer to as your nursing process. If you can recall the definition of nursing process, it is a systematic approach and a dynamic process used to deal with the care of our clients. Your nursing process would have 5 phases: assessment, diagnosis, planning, implementation, and evaluation. So, as a process, it is considered to capture holistic nursing approach, meaning we do not only treat the disease of the patient, we do not only consider the physiologic aspect of the patient, but we consider the patient as a holistic human being with consideration to his biophysiological, sociological, psychological, or mental state. So, nursing process is applied in the initiation, maintenance, and even in the evaluation of the treatment being given to the patient. What do you mean by that? By the time that the medication is given to the patient, by the time that we initiate treatment, we assess. We do an assessment prior to starting any therapy. We do diagnosis before we give a certain medication. We plan for the patient. We implement the care of the patient and then we evaluate it later on. If your patient is having maintenance medications, the same nursing process is still applied. For example, if I'm talking about a patient who is hypertensive, he needs to be maintained on anti-hypertensive medication. So I need to assess the patient. How would I do that? One, I need to have an assessment of the blood pressure of the patient to establish that indeed the patient has hypertension. Two, I need to take the laboratories of the patient or ensure that the laboratories are completely complied by the patient, such as, for example, your creatinine, your SGPT, because I would want to make sure that the kidney and liver functioning of the patient is okay prior to starting this medication. Okay, that is how we apply your nursing process. Also in evaluation, in any treatment that we give to our patient, we always evaluate. Okay? You could not give paracetamol and then just let your patient be. You need to evaluate after 30 minutes, after 1 hour, if the patient is responding to treatment. The same way, if your patient had been sick for hypertension, if you have given clonidine or catapres, you're more familiar of catapres. Catapres is used for the acute management of your hypertension. We do not stop by the time that we have given paracetamol or catapres to our patients. Okay, we only stop our interventions once we have evaluated that indeed the patient has responded to the therapy given to him or her. Okay, that is your evaluation. So this slide is just a reminder that whatever the procedure that the nurse is doing, may that be at the bedside on polycatheter insertion and this time in medication administration, the nursing process is still assessment, diagnosis, planning, implementation, and evaluation. Other literatures would talk about assessment, analysis, planning, implementation, and evaluation. So it's still ADPIE for that matter. Let us discuss the first step. So assessment. Your assessment will form the basis in which the care is planned, implemented, and evaluated. So in this case, when I say assessment, it's the basis. Okay, when will we give the drug to the patient? Is it about time to give the drug to the patient? Will this drug be beneficial to the patient? All of those questions can be answered by assessment. So, in assessment, we collect both the subjective and the objective data. And then, as I have mentioned, this will be the basis for the care plan of your patient. So, without proper assessment, we will have problems with the way we deal with our patient. We will have problems on the diagnosis, consequently, the planning, implementation, and evaluation. For that reason, we are emphasizing on what are the important assessment findings that we need to before we give a particular medication. Again, as a particular example, prior to administering digoxin, which is a cardiac glycoside, we would like to check the pulse rate or the apical pulse of your patient or the heart rate of your patient because we would want to make sure that the patient will not have bradycardia because one side effect of this medication is to decrease your heart rate. Another example would be when you're giving an antihypertensive, a common example perhaps are drugs that ends with olol. So when I say metoprolol, when you give your metoprolol, an antihypertensive, you need to check the blood pressure of the patient. Why? If the blood pressure of the patient is 80/50, you are supposed to hold the medication temporarily and inform the physician. Why? What is the reason? If you will be giving an antihypertensive to somebody who is hypotensive, you are aggravating the condition of your patient instead of helping them. So that's how crucial your assessment findings will be. Okay, that's why we refer to it as a basis for our care plan. Now, in assessment, we identify priorities. We collect client data. There are two ways for us to collect. When I'm talking about objective data, we collect objective data through physical assessment, whereas subjective data is collected through your interview. Okay, so you collect data, observation, interview, physical examination, continuously updating the database of information. So as nurses, we just don't rely on what is written there, okay, by the previous shift. Instead, we continuously update this database of information. Why? It is not because we do not trust our companion, but it is because that the condition of the patient may change within a short period of time. So we need to recognize significant data. We need to validate our observations and recognize patterns or clusters. Let's say, for example, if I'm talking about a patient with hypoglycemia, a patient with hypoglycemia would have signs of diaphoresis or excessive sweating. Okay, cold extremities for that matter, inability to focus. So these are clusters of signs and symptoms that would signal you that the patient may have hypoglycemia. And if your patient is having hypoglycemia, are you supposed to give the insulin injection of the patient? That will be the time that you need to think twice before you inject your insulin. Because remember, your insulin is intended to decrease the blood sugar of your patient. So if you give insulin to somebody who is hypoglycemic, you are aggravating the condition of your patient instead of helping your patient. Also, we identify strength and problems. What do I mean by strength? If I know that the patient is responsible on medication administration, it means that I could trust my patient. If I know that the patient is capable of doing the activities of daily living, I know that the patient will be able to take the medication by himself. Identify problems. If I know, for example, that my patient has Parkinson's, Parkinson's is a disorder characterized by bradykinesia, rigidity, and resting tremors. So imagine somebody with resting tremors. Will my patient need help when it comes to medication administration? Yes, they would. Because they might not be able to grasp a tablet, they might not be able to open a tablet from its container or to open the container of the syrup. Those are things that you need to consider in assessment. And then we analyze data to reach into conclusion. For example, if I'm in doubt that the patient indeed is having hypoglycemia, I mentioned the three signs: diaphoresis, cold clammy skin, inability to focus. I'm still in doubt if this is hypoglycemia. I would add another data, for example, with the use of my CBG machine to monitor the blood sugar of the patient in such a way that I can make a valid conclusion that the patient is indeed having hypoglycemia. So these are all part of your assessment. Now, let's talk about subjective data. So subjective data, I would want to assess the capability of the patient to swallow. Is there any difficulty in swallowing? Because if there is, we will have a problem in compliance with tablets. We also ask the signs and symptoms of the patient. What are the symptoms currently experienced by the patient? What are the current medications? So you ask them, what are the purpose for this medication? What is the expectation for this medication? When to return, and how are you complying to these medications? Okay, you need to allow the patient to verbalize these medications. You might be saying, oh, they're patients, they're not supposed to know the technicalities of the medication. Ladies and gents, if your patient was able to understand what the medication is prescribed for, they will be able to tell you as a nurse. It will be a part of your assessment because later on that will give you a hint that your patient is having deficient knowledge on the medication. A good example for this will be your sildenafil. Sildenafil, Viagra. Your Viagra is used for erectile dysfunction, as most of the people would commonly know. But take note, not all of your patients who use Viagra would have erectile dysfunction or use it for erectile dysfunction. You will encounter patients that are using sildenafil or Viagra for cardiac conditions. Okay, take note of that. So not because a certain medication is used by patient A for this purpose, that will be the same purpose for patient B. So that varies. Okay, take note of that. Then you need to check for allergies or reactions. We do not just focus your allergies and reactions here on medications, but that's one thing that you would want to ask. Sir, are you allergic to any medication? So for example, if the patient will say that he is allergic to penicillin, penicillin is an antibiotic. Okay, penicillin is an antibiotic, common antibiotic. But we need to know as nurses that when we talk about penicillin, there is cross-sensitivity to another classification of antibiotics that we refer to as cephalosporins. Okay, when I say cephalosporin, an example of this will be ceftriaxone. So what do I mean by cross-sensitivity? There is a possibility that if my patient is allergic to penicillin, he may be allergic to a cephalosporin too. So you also ask for reactions. So some of your patients might say, oh, when I took this drug, I had hives, I have rashes all throughout my body. And other patients will say, oh, I just had a mild reaction, it was just itchiness. While others will say, oh, I had difficulty of breathing because of this medication. So you need to take note of that. Okay? But one thing that you need to remember about hypersensitivity reaction is that there is a possibility for the hypersensitivity reaction to be more severe on the second exposure of the patient. So what do I mean by that? On the first exposure of the drug, if the patient would say, oh, I just had itchiness, you do not say, oh, okay, if I will give this medication, he will just experience itchiness. No, it may be possible that on the second exposure to the drug, the patient might have already developed hypersensitivity reaction. Okay, the patient might have been sensitizing this allergen, and on the second exposure, it became more severe. Next, you need to ask about over-the-counter medications. Okay, so in this question, you do not give your patient a cue that over-the-counter medications are bad. Okay, you just ask the question, sir, may I know the other medications that you're taking? Are these medications prescribed by your physician? Could you tell me the purpose why you are taking these medications? The same for your herbal remedies. Okay? The same for your street dogs and alcohol consumption and smoking. Although an inexperienced nurse would have hard time, okay, to elicit the information about street drugs, alcohol consumption, and smoking from the patient. But try to observe the cues. Experience would teach you later on. Okay? And then when you're asking questions about street drugs, alcohol consumption, and smoking, ask these questions directly. Okay? Sir, are you using drugs? Sir, are you consuming alcohol? If he answered yes, how much in a day? Okay, how many bottles in a day? What type of alcohol are you consuming? Sir, are you smoking? Okay, you ask direct questions for this one. Okay, then language and communication needs. You don't always assume that your patient understands you. That's why one of our premise in pharmacology is that if there is a skill that we are teaching our patients, we need to ask them to do a return demonstration. Okay, if you're talking about cognitive skills or we're talking about cognitive items for that matter, we ask our patient to state back what we have stated to them for us to ensure that indeed our patient was able to understand what we were talking to them. Now let's talk about the objective data. In objective data, we assess the range of motion of the patient. So we are looking into the joints of the patient. We are looking if the patient is able to move the wrist joints, okay, the phalanges, and then the elbow for that matter. We're also checking the muscle strength of the patient if he is able to carry out medication by himself. If the patient is having problems with medication administration, we may provide equipment such as your anti-spillage glass, okay, to prevent accidents during eating or during medication administration. We also check for visual acuity. Is the patient able to recognize that this medication is the one indicated on the label? We also perform your physical assessment to watch out for changes that may indicate kidney and liver damage. For example, edema, okay, or fluid deposits on the extremities. Peripheral edema is an indication that your patient is having a kidney problem. If your patient is having jaundice, that would indicate that your patient is having hepatic problem. We also assess the organs of the patient for that matter. Let's talk about diagnosis. So the nursing process, nursing diagnosis. In diagnosing, this involves identification of clients' actual or potential health problems. So problems can be managed by independent nursing action, and they provide guide for identifying nursing priorities and directing nursing care for the patient. Okay, so that is our role in nursing diagnosis. So when I talk about nursing diagnosis, our main basis again would be, okay, your main basis will be your assessment. Hence, a wrong or an incomplete assessment will lead to a misprioritized problem. Okay, abnormal data. So your abnormal data will be acting as your defining characteristics and then your risk factors for your nursing diagnosis. If you can recall, your nursing diagnosis would have three parts, especially if I'm talking about an actual diagnosis. An actual nursing diagnosis would have problem, etiology, and then signs and symptoms. So you have your P, E, and S as the parts of your nursing diagnosis. However, if I'm talking about your risk diagnosis, there are two parts. And the two parts of your risk diagnosis are your problem and etiology. Okay, so this etiology and signs and symptoms are based on the assessment findings that you have. Okay, let's see some of the common nursing diagnoses. So you might have language barrier or speech articulation problem. So this is the problem that we may can encounter related to muscular weakness. Deficient knowledge about action administration and side effects related to anxiety. Because oftentimes, class, your patient might be encountering the condition, might be encountering the medication for the first time, and they're anxious about it. Okay, they don't understand how it works because they were not listening by the time that you were talking to them, because their main focus is how can they survive the condition that they just knew. Then you can have acute pain related to hesitancy in taking prescribed pain medication or fear of addiction. So that could be acute pain or chronic pain. Chronic pain, 6 months or more. Now, oftentimes, class, your patient who are on pain would say, I would not take the medication because I'm still not on pain. So if we anticipate pain as healthcare professionals, we usually give pain medications round the clock within 24 hours. So when I say round the clock, these pain medications are given every 6 hours, for example, routinely for the first 24 hours. Okay, this is commonly done if we're talking about post-operative patient. Why? If your patient have undergone surgery, you would expect that hours after the surgery, your patient would start to experience pain. Immediate post-op, your patient is not feeling any pain. Why? The effect of anesthesia is still there. But once the anesthesia would wear off, your patient would start to feel pain. And if the anesthesiologist would prescribe to give pain medication once the patient is fully awake and once gag reflex is there, the pain medication is ideally to be given. Why? What is the rationale of the anesthesiologist for doing that? The anesthesiologist would not want your patient to experience severe pain before the medication is given. Take note, onset of action. When I say onset of action, it does not mean that if I will be giving your medications right now, after a minute, it will have an effect. Okay, remember that the onset of action for some of the medications may be up from 30 minutes to 1 hour. Okay, and then some of your patients may also say that they have fear that they will be addicted on pain medications. So class, drug tolerance and drug addiction, if they have concern, can be talked to the respective physician. Not all pain medications develop tolerance, and not all pain medications would have a problem leading to addiction. Take note that the doses being used in the hospital setting are regulated and well studied. Hence, the risk for tolerance and addiction should have been eliminated, if not minimized. Then we have ineffective health maintenance related to not having recommended preventive care. So your patient has a tendency, okay, not to follow the recommendation given to him. And then your patient has a tendency to rely only on the medication. That take note, class, that the management of a certain disorder does not rely on medication alone. There are a lot of disorders whom we need to be managed, that needs to be managed, okay, by your lifestyle changes and dietary changes. Then we also have ineffective protection related to effects of anticoagulant medication on clotting mechanism. So class, anticoagulant. So coagulation. Coagulation supposedly stops bleeding. But we have medications such as anticoagulant which are given as blood thinners. So if we're giving blood thinners to our patient, one risk that may possibly occur to our patient is that they will be at risk for bleeding because also of the side effect of this anticoagulant. Then, non-compliance related to forgetfulness, very common. Risk for injury related to side effects of the drugs. That's why, ladies and gentlemen, we need to educate our patient on the common side effects of medication. For example, as simple as furosemide. Your furosemide, as I have mentioned, is a diuretic. Okay, as a diuretic class, it can reduce also the fluid volume of the patient in the body. Because of the decrease of the fluid volume in the body, your patient would be at risk for low blood pressure. So what's the concern if your patient would have low blood pressure? If your patient would have low blood pressure, it is not ideal practical for your patient to stand. Because if your patient will stand and ambulate or walk around the room, the tendency is for your patient to fall. Okay, so this is not the fall that we would want to happen. So risk for injury related to side effects of medication. Then we have ineffective therapeutic regimen, management related to lack of finances and healthcare coverage to purchase the medication. So this is the reality of our situation. So that's why we still educate our patient and then we offer them possibilities of having resources such as your social worker. Then we may have deficient knowledge related to effects of anticoagulant medication on clotting mechanism. And then readiness for enhanced knowledge related to schedule and medication side effects. That's why there are cases wherein we will be giving medication information sheets to our patient to ensure that they fully understand the side effects of these medications. Okay, so that is for your diagnosis. In the succeeding video, I will be discussing about planning, implementation, and evaluation. Thank you very much for your attention on this lecture.